This conference will now be recorded.
Okay, great. Hi, Dr. Kahn. Thanks for taking the time to speak with us today about your book, The Next Pandemic: On the Front Lines Against Humankind's Gravest Dangers. We're excited for the opportunity to speak with you. The questions that facilitate this discussion were submitted by public health students across the United States. So, Dr. Kahn, if we could begin with you telling us about yourself, your background, what motivates you professionally and perhaps personally to explore some of the world's deadliest diseases and the panic and corruption that makes them worse.
Hi, Kate. Thank you very much for the opportunity to chat this afternoon, and thank you very much for selecting the book, The Next Pandemic, for your book club. So, as most of the students who read the book know, I'm currently Dean of the College of Public Health here at the University of Nebraska Medical Center. And prior to joining the University of Nebraska Medical Center, I spent about 20 years at CDC sort of dealing with health security issues. So the most dangerous pathogens in the world was sort of my body of work, and then making sure communities were protected against those agents.
Great. So, at the close of your book, you include a list of illnesses that could become devastating. You offer some solutions, such as international systems for sharing of information and data. What are your thoughts since you wrote this book on how well we are doing to prepare for the next epidemic? And do you see changes in the global partnerships as a result of current conflicts and situations across the world and not just in the US?
So I have seen changes, continue to see changes. Unfortunately, the pace of change is quite modest. So let's start domestically. Domestically, if we look at our National Health Security Preparedness Index, it's a 6.7 out of 10. This is despite over a decade of investments in preparedness, and that's really not adequate for the United States. And that bridges over to globally. So unfortunately, what happens is that we get spasms of support and resources for public health activity. So after 9/11 and the anthrax attacks, after SARS, after Ebola, and this is not just a national phenomenon, it's a continental and global phenomenon, or H5N1, the bird flu. Everybody gets interested. There's a large interest in it. There's a large interest in preparedness. But as that gets in the rearview mirror, that fades. But unfortunately, the interest doesn't fade at the local, state, national, international levels, right? Because they have to make sure that they're prepared because these epidemics are inevitable, bioterrorism is inevitable one day, and so they need to be prepared. Here in the United States, we need to think about why has funding decreased for these activities, and we probably need a brand new strategy. How do we get away from these incremental increases in preparedness to some major increases in preparedness, especially in the domains where we're weakest. We're weakest in healthcare preparedness, and we're weakest in community engagement. And that is the direct bridge when I talk about international preparedness. So when we look at preparedness in other countries, those are their weakest components. The current Ebola outbreak is a great example of the weakness in community engagement, community resilience, the weakness in health systems where physicians and healthcare workers are continuing to get infected, and often the start of many outbreaks are within healthcare settings because they don't have good infection control practices. WHO during the current outbreak has shown really much greater leadership and technical expertise, and that's clearly incorporated a lot of the lessons from the large 2014 Ebola outbreak. But it's clear we still have much to do at the international level. So for example, here's two things that people should be working on and our students can think about. One is we don't have an undersecretary for health or health security at the directly reporting to the Secretary General of the UN. And I think we need somebody at that level to think about health, because health is so much more than what's being done by WHO. It's really cross-sectorial, and having that sort of political leadership I think would be appropriate. And we see it happen during large outbreaks. Invariably there's some sort of UN representative because people realize it's needed. Also, we don't have a good financing strategy for global outbreaks. And it would be good to get the World Bank to step up and not just have their emergency financing facilities, but think more holistically about how do you finance outbreaks responses, but how do you finance preparedness? So there's a long-winded answer to modest gains, but much to be done in both domestic and international preparedness.
So it makes sense. I mean, it makes sense. And so you suggest with potentially having a position as an undersecretary position and maybe recalibrating the financing, that's how we can kind of move away from the incremental changes into the bigger, more sustainable changes.
Correct. And it's a reflection of the fact that we need political leadership when you think about preparedness. It's not just having excellent public health and healthcare activities, but we need political leadership to say this is important, and we are going to continue to have a sustained effort and new, innovative, creative thinking to get us ready.
Great. So kind of on that same note, you mentioned a number of, will we ever get to the level of trust required to share needed data and information between countries to effectively combat outbreaks and prevent pandemics? And, if so, what do you think is required to achieve that?
So we should be comforted that there's much better collaboration, country collaboration, agencies collaboration within countries and across countries for sharing data. I think SARS was a wake-up call in many ways for us. It reminded the world that due to air travel, you can be anywhere very quickly and
Right.
definitely less than an incubation period. And China initially tried to hide their SARS cases, and that didn't work. And I think most countries now realize you can't hide cases of communicable diseases unless you decide to essentially shut all travel into and out of your country and all news feeds, right? Because the news will get out, right? So I think countries realize that they need to share information about outbreaks. The last set of difficulties we had was with Saudi Arabia and the MERS outbreak. They were not very forthcoming in sharing information, and they've also have changed completely. Now, every case in Saudi Arabia, they'll give you a complete description of the case, who it was, how they got infected, and what happened. So I think that part has been fixed. What has not been fixed is flow of other sources of information and specimens and data about outbreaks. And I think, we've made progress when we were trying to get influenza strains from Indonesia. So we've made progress, influenza being a good example, but not enough progress, because how do we make sure that as we work with collaborators worldwide, that the individuals who are collecting this data or specimens have appropriate property rights and copyright rights, so that all the scientific effort isn't being done at one place, and they're getting the patents and they're getting the publications and they're getting the grants, but all the real field work is being somewhere else. Right. So I think until we have an overarching global compact that deals with that, we're not going to make as much progress as we need to make in that absolute complete free flow of information and specimens.
That's interesting, and I also think that there probably is an ethics component to that as well, which is huge.
You're spot on, Kate. There's absolutely an ethics component to that if you're going to take information from country A to help you make a vaccine to protect your individuals, how do we make sure that the people in country A who are affected and share those samples with you are also protected? So there's absolutely an ethics issue, and that also goes to the copyright and the scientific rights of data from the people collecting the data, to make sure that they get appropriate contributions and author acknowledgements. You still there, Kate? You're frozen. Like you're really frozen. Come in.
Sorry about that, Dr. Kahn. Are you?
No worries. It's good to have you back.
So we were chatting about the ethical component to the information sharing.
And I said you were spot on in recognizing the ethical components of information sharing. How do we make sure that if we're taking specimens from a country and then using those specimens to develop countermeasures, that those countermeasures are also available back to that country who's provided the original samples to you, who are also having this disease? And the same thing for this, how do we make sure that we're acknowledging the scientific contributions of people in other countries who are generating that data?
Right, right.
And so this is, I think this is, Kate, just bigger than standard data use agreements. I really think you need some sort of global compact or something along those lines so that people don't think twice that during a pandemic we need to share samples immediately, because
Right.
they know that all the processes and safeguards are in place that will retain their patent rights and author rights and everything else.
So some accountability measures as well.
Correct.
So that's a major feat. So you mentioned a number of faith communities in your on-the-ground work in Africa. What messages might you share about the value of such groups improving health, regardless of where they're situated?
So faith communities, to me, I think is a double-edged sword, a two-sided coin. So a lot of the practices in the communities where we work that spread infections are a function of sometimes cultural or religious based customs, like washing bodies who have been infected with a lethal pathogen. Not a good idea if that's a communicable disease. Or I see that in charismatic faiths where they lay on of hands if somebody's sick, right? So basically, these religions share a common sense of the divine and helping their neighbor, and what are really good practices that show your respect for the individual or the individual can spread infectious diseases, right? So it's a good thing when you're healthy. It's not such a good thing when you're carrying a lethal pathogen. So for me, that's a great opportunity to work with these communities to help them understand that we're not denigrating their practices, which we respect, obviously, but that in this circumstance that they need to be modified and why they need to be modified to protect the community. That's one piece of it. The other piece of it is that these religious leaders and traditional healers are also, they're leaders within their community, not just of their faith organization necessarily. And so they can be wonderful advocates for sharing great messages within the community on how people can protect themselves. So I believe that we should be, before an outbreak, we should be including them in our preparedness planning. To help us think about how we would respond to an outbreak, how we would recognize an outbreak, how we would recover to an outbreak, and during an outbreak itself, we should be engaging them right away with the best possible information that they can be sharing within their community. So I hope to see them as much larger partners moving forward in all of our preparedness and response activities.
Are you aware of any progress being made on a universal influenza immunization?
A great question, links very closely to the book itself, because as I've said, an influenza outbreak is inevitable. These are zoonotic viruses. Wildfowl are the zoonotic host reservoir for these pathogens, and they have this wonderful ability to switch genes, and when they switch genes, then they can be completely new to our immune systems and can be very deadly and communicable. So unfortunately, as most people know, you get vaccinated every year. And we get vaccinated every year because the flu virus slightly changes every year, and we call that antigenic drift. And that's why you need to get vaccinated every year, because of those constant changes of seasonal influenza virus. And that doesn't help you, the vaccine doesn't help you at all if there's what's called a shift, when it's a completely new coat on the influenza virus. That doesn't help you at all. So then the vaccine you had, you actually have to make a brand new vaccine to that new influenza virus. The influenza virus vaccines are not all that great. Better than none, I want to be very clear, but not all that great. Better, obviously, at preventing death and hospitalization than preventing illness. So one of the holy grails of public health preparedness, and definitely influenza, is the so-called universal vaccine. And there's different ways to define what a universal vaccine is. But the biggest issue being, can you have a vaccine that potentially protects you against any type of influenza? So there's lots of work on that. It usually follows 2-3 different paths. One path is to use a little conserved protein on one of the key elements of the influenza virus and go against that key conserved protein. And then there's other approaches where you have sort of a cocktail of various proteins against things besides the coat that you put together. So there's lots of work on trying to get a universal flu vaccine. And it would be a dramatic improvement in our preparedness if we get there. Also, as I said, hopefully during the course of that work, we will develop better flu vaccines because our flu vaccine isn't very good.
Yeah, and I think they're actually commonly misunderstood. I mean, I certainly didn't realize that, the flu vaccine is not a guarantee that you're not going to get the flu. It kind of just is a preventative measure, I guess, right?
You're spot on. And this is, Kate, I hear from patients all the time, well, I got the flu vaccine and I still got the flu. And I go, yeah, but you didn't die. So,
right. That's right. Every year. Like, why am I getting this flu vaccine?
Right. So it is definitely better in preventing severe complications than it is in preventing mild or minor complications. So we need a better flu vaccine in general. But flu is pretty wily. It changes. It's one of the most inventive in terms of genetically changing every year, and so it keeps us on our toes.
Hard to track down. So what's the risk of bioterrorism as it gets easier and easier to create and recreate a virus? This is a really interesting question.
It's absolutely a great question. So I would like pandemic influenza. I would say that bioterrorism is inevitable within my lifetime, without a doubt. And the reason I say that is there's always been intent, right? So there's a lot of people out there who want to do bad things to us. So there is the intent. We know there's the intent. We also know there's the capability to use biologic agents to do bad things. And we have examples going back hundreds of years where people tried to do it by launching, the siege of Kaffa, launching dead bodies, plague-infested dead bodies, to try to get people infected. Fast forward a couple of hundred years, and we've had very advanced bio-offensive programs by the US, Russia, and other countries. So we know you can do it. Fortunately, what's not happened so far is that the people who want to do it don't have the capability to do it. But the moment those two pieces come together, I expect that people would use biologic weapons to inflict terrorism within their communities. And my biggest concern is that this capability to use biologic weapons gets easier and easier every year as the science and the technology disseminates broadly. So for example, think of something like PCR, right? So I think Kary Mullis, 1993, 1998, got a Nobel Prize for doing PCR, to help us understand how to do PCR. High school labs now do PCR, right? So that's how far this advanced technology has disseminated into our communities, from Nobel Prize to high school students.
That's wild to think that.
Right? So my biggest concern with bioterrorism is not somebody in a cave becoming a terrorist, but I'm more worried about potentially a microbiologist who understands how to do this becoming a terrorist.
Right. Yep. That's why we need constant communication and open discourse and dialogue.
Absolutely. And how we need to make sure we instill a full set of ethics in individuals who work on biologic agents, and help them understand sort of their global role in protecting those pathogens and securing those pathogens as they work on them.
Mm-hmm. So what training programs do you see that are needed to prepare the public and private sector for a pandemic or a natural disaster?
So fortunately, we do have some of these training programs within colleges of public health and other colleges, but we need to think a little bit better about a community-wide holistic approach to preparedness. Right, so it's not just the public health sector, but it's the business sector, also the infrastructure, utilities, etc. So we need programs that help communities understand how to prepare and how to be resilient. We need programs with private companies to help them understand how to be more resilient and how to make sure that they're prepared if 20% of their workforce doesn't show up tomorrow. If you know, let's say 10 to 12% of the people at my power plant don't show up, I would really like to know the power is still going to be on that day, right? Uh, so how do we make sure that there's that preparedness? Also within the healthcare industry is another one of those critical infrastructures. You know, people say, or sometimes I hear from people, pandemic influenza 1918, it's not going to happen today. And I can give them 100 different reasons why it's going to happen today. But the easiest things to say is, what happened at your hospital at the last flu season? And they go, oh, they diverted people, the ERs were full. And I'm like, there you go. So during a regular seasonal influenza outbreak, the hospitals are already overwhelmed. What do you think is going to happen during a pandemic? Right? So I think we can do a lot more within healthcare preparedness to help the healthcare system see itself as a whole that includes nursing homes, physician practices, EMS, and to do better. So there's a lot of places for education throughout and training throughout this whole process. A lot of opportunities for students interested in this work. CMS, the Center for Medicaid and Medicare Services, is already asking all healthcare facilities to think about what their preparedness plans are for pandemics, and I would like that to see that expanded to businesses in general.
Mm-hmm. So we have a public health student that wrote in asking, of all the stories you tell, the one that stood out was the story of the 2001 Anthrax Letter sent to a member of Congress and the resulting deaths, especially of people who worked in the post office the letter was processed through. This story demonstrated the need for communication and partnerships across disciplines, as well as with partners around the world. This example also clearly demonstrated where the role of a disease detective comes in, finding the index case. What suggestions do you have, Dr. Kahn, for those who are interested in becoming an EIS officer?
So becoming an EIS officer really was the highlight of my training career so far. Wonderful 2 years working at CDC, and I would encourage others to do so. And there's lots of ways to do that without just specifically becoming an EIS officer. But to become an EIS officer, you have to have a doctorate degree. So that's a requirement, DVM, PhD, MD, DRPH. But that's just, the foundational requirement. Really, to me, it's about a sense of curiosity and a sense of commitment to public health. And that's what it takes to become an EIS officer. That's what it takes to sort of fret out an outbreak and figure out, this is the chain of transmission and this is what's going on.
Mm-hmm. Would you recommend pursuing a career in a state, local, or tribal health department?
So if I could redo my career again, when I did EIS, I would not have done it at CDC. I would have done it at a state, local, or tribal health department. And the reason I say that is, and I say that to my students who come to me at CDC, they're all excited to come to the mothership, come to CDC, but I try to remind people, and this is even more poignant to me now being here in Nebraska as a dean, that public health doesn't happen in Washington, D.C., it doesn't happen in Atlanta, it happens in our communities. And if you really want to understand that it really is beneficial to work at the local and state level to understand how public health works, and that can then help you think about how you formulate better policies that will be effective at the state and local levels.
I think that's so true across that spans disciplines for sure. So we really appreciated the following phrasing: the true definition of global health, striving to improve the condition of people worldwide, regardless of GPS, global positioning system, coordinates in an accident of birth. From your book, what advice do you have for how public health practitioners should focus their efforts given this context?
So, thank you for that comment. It reflects my cynicism about the term global health sometimes, because, for example, I send students to China and they call it a global health experience, and my Chinese collaborators send students to work with me and they call it a global health experience. So how can they both be having a global health experience when they're having a local experience in another country? It makes no sense to me, okay? But so what the heck is global health? So I think some of this about global health to me is, what are the commonalities that drive disease in our communities and help us think about prevention strategies within our communities? So I think some, not everybody, colleges of public health have markedly advanced, but some people's sense of global health is sort of a mindset from 40 years ago of what the global north does to the global south, or the formerly called developing countries versus the developed countries. And all of that just doesn't make sense anymore. And if your students want another great book to read, I would tell them to read Factfulness by Hans Rosling. So, these lower middle income countries, this is now less than 1/7 of the global population. The majority of the world is middle income countries. And so the majority of the world, yes, there are places where they're worried about malaria and for example, but the majority of the world has the same set of public health issues, often around chronic diseases, often around mental health. And those solutions are not limited to what works best in New York City versus what works best in Sao Paulo. We have stuff to learn from each other. And I think that's what global health to me is how do we learn from each other's experience and best practices to say, how do we modify our strategies to address common health issues for the benefit of our community? So that's what global health is to me.
So I want to be respectful of your time. So I'm going to ask you one more question and then kind of leave all of the students that are going to be listening to this with words of wisdom from you. So you recognize the importance of cultural awareness. So for example, the story you gave of the custom in Africa of washing the bodies of the dead, which you spoke about briefly in the beginning of this. Do you have any recommendations on what, and just basically what is needed to be more culturally aware?
So this is something that, I'll be very honest with your students, I struggle with all the time, because the hardest part about being culturally aware, so there's easy answers to culturally aware, right? Active listening, right? Treat people as individuals, be humble in your interactions with people. So those are the easy answers. But the harder answer is to say that your worldview is not the only worldview, and that there may be a different worldview that's as valid as your worldview. And that thinking is hard to do, but I think that's what you have to do to be culturally aware, because in any interaction we have with anybody, and culturally aware, it's not just about race, ethnicity, country of origin, gender affiliations. It could be two people of the exact same race talking to each other who happen to grow up in different parts of the country or something, right? Same religions. We walk into every conversation and interaction with a set of our own biases and interactions with people over our lifetime that is different from the person we're interacting with, right? And then how do we sort of put that aside and say, I'm going to treat you as an individual in your own right and respect your set of conditions that you walk in the door with. And so that's the challenge to your students, to what it means to be culturally aware. As they're willing to set aside some of their biases about life and their worldview, to actively listen to somebody as a blank slate about what they have to tell you about their life and their worldviews and their needs within the communities.
Right. Well, do you have any, I mean, that was pretty powerful closing, but do you have any, last thoughts or advice for public health students, the public health community who will probably be listening to this as well?
For our public health students out there, what I'd like to share with them is I've had a fabulous career in public health. I didn't think I'm an accidental public health practitioner. I was supposed to go off to, become an infectious disease doctor working on clinical medicine and research. And I had the wonderful opportunity to go to CDC and fall in love with public health, and I'm still in love with public health. I don't believe there's any nobler passion than public service, and public health is one of those public service groups. So I couldn't suggest to them a better career than public health. They will be intellectually challenged their whole life, and they will be rewarded for their work their whole life. So I'd encourage them to, be passionate, go out there and become public health practitioners. Oh, and advice for students specifically: get good mentors. I had great mentors all the way. So my advice to students as an ending comment is, please get good mentors out there and become great public health practitioners.
Dr. Kahn, it was so wonderful talking to you. I feel so reinvigorated. Really, I'm remotivated. It's not every day you get to, I feel a lot of times these conversations need to happen, but people don't make time for them. So we appreciate it.
Kate, you were wonderful. Thank you for a wonderful conversation.
Thanks. And I'll be in touch with Kathy and, let you know when this is live and everything.
Thank you. And you'll try your best to try to make me sound smart.
I don't think I have to try. Have a nice week.
You too. Cheers. Bye-bye.
Bye.